Thank you. I'd like to start off by thanking Gary and Neil for giving me the opportunity to speak to you and to get more familiar with ChildKind. So I was asked to talk about America's opioid epidemic and using opioids in the time of this crisis, as it's been called. I may have given away the theme of my talk by putting exclamation points around the word epidemic. But I think that'll become, why it will become obvious in a few minutes. I'm not used to holding a microphone. No disclosures. I don't do any pharmaceutical consulting any longer for industry regarding opioids or actually anything else at this point. And I want to just start the talk by giving you some generic disclosure, which is that I don't consider myself to be a pro-opioid or anti-opioid. But I do use opioids, as I think everybody in this room use. And the reason that we use opioids today is simply because we know they work. They work for both acute pain and, in many instances, chronic pain. Opioids are lousy drugs. I don't think any of us really like them. They cause a lot of side effects. They have a very small safety margin. But for thousands of years, opioids have been used. In fact, and you have to ask the question, why for 4,000 or 5,000 years have opioids persisted in use in clinical practice? The reason is because that they work. If they didn't work, we would have abandoned them a long time ago, like leeches, for example. We use them because the clinical evidence, whether or not there are randomized controlled trials that show that they're effective in chronic pain, the clinical experience dating for hundreds and thousands of years is that they are indeed effective. There's only one other class of drugs that is as old as opioids that remains in persistent use to this day, and those are the non-steroidal anti-inflammatory drugs. The first description of their use was probably by Aristotle, who found that if he chewed the bark of the willow tree, his headache went away. And it was good for fevers as well. And we persist in using non-steroidal anti-inflammatory drugs for all these years for exactly the same reason. They simply work. And we've made chemical modifications in these drugs to make them absorbed more readily or shorter acting or longer acting, but basically the molecules are the same and we continue to use them. Now, we've heard a lot in the press about the opioid epidemic, and there's been a lot of inflammatory language. Here is some of the inflammatory language. The opioid epidemic, the opioid crisis. Opioid is creating a labor crisis, opioid use, which is ridiculous on its face. We're a country of 300 million people, and the fact that 30,000 are dying every year from opioids, it seems ridiculous to think that our labor market is being affected by some number such as that. Heroin overdoses are taking over our children. What I want to do with the first part of the talk is to puncture some of the mythology and some of this inflammatory language that's used to describe opioids and the situation our country is in, but being realistic about the fact that there are a lot of people who are dying from opioid use disorder. I want to talk about where opioid use disorder comes from and what the causes and the predilections that lead to this problem. And then I think we're going to run out of time. Having laid that foundation, I could talk another hour about what to do about the opioid crisis, in my view, and a little bit about what you and I can do as healthcare providers, as hospital administrators. But I'm sure we're going to run out of time before that, and we'll save most of that discussion, if there is any, for the Q&A. Now, up till a couple of years ago, this was the curve, according to the NIH, of the number of individuals dying in the United States from all opioids. This includes medical use of opioids, non-medical use of prescription opioids, and street narcotics. And as you can see, it was really looking like it was leveling off until 2014, and then actually starting to trend downward, which was a very, very good thing. But in the last few years, this has happened. We've seen a dramatic increase in the number of opioid deaths. The opioid crisis, or the opioid epidemic, has been dated to about 2000 or 2001, when there was a rather rapid increase in the number of deaths occurring in emergency rooms and on the street from opioids. More recently, as you can see, there's been this rapid increase, which has just inflamed the media and many of our politicians even further. But where does that come from? This is the curve that looks at just the number of deaths from heroin and fentanyl. And if you compare it to the previous curve, you'll see that up until about 2010, 2011, the majority of deaths were related to prescription opioids. Now, we don't really know how many of the prescription opioid deaths were related to the medical use of opioids and how many to the recreational non-medical use of those opioids. But the sense of experts everywhere is that the majority of deaths going from 2001 to 2010, when the curve started to inflect upwards, were from the non-medical use of prescription opioids. And this doesn't come as any surprise because anybody with a computer was probably bombarded with 2 or 3 emails a day offering to sell you Vicodin without a prescription from pill mills largely located in the state of Florida. This has gone up even more in 2016. So now you can see that the majority of opioid deaths in the United States are from street opioids, heroin, and in the last year or so there's been a real skyrocketing in deaths because of the contamination of street heroin with Mexican fentanyl. It's a real problem. So the lesson here is that the medical use of opioids represent a minority, probably about 35 to 40% at the maximum of the number of opioid deaths in this country, and the vast majority of those deaths are from recreational use of opioids, medications, not from the legitimate medical use of those opioids. I want to talk a little bit about the words epidemic and crisis. Now, this kind of curve does look like a crisis, and we're on target for 2017 to have in the range of 30 to 35,000 deaths in the United States. That sounds like a lot of people, right? You hear people say, well, that's 90 people a day dying. That's equal to 10 9/11s. And it's very, very scary idea. So let's just compare that to some of the other causes of death in this country. Tobacco kills 345,000 people a year from cancer. 55,000 people die from secondhand tobacco smoke, according to the CDC. That's 1.5 more times people die from secondhand passive smoking than die from opioids. All causes of opioid deaths. Altogether, there's about 450,000 tobacco-related deaths in this country a year. Most of them cancer, the rest from chronic lung disease and other illnesses that are associated with tobacco, like peripheral vascular disease. There's almost 90,000 deaths from alcoholic liver disease and another 20 or 30,000 deaths from alcohol-fueled highway accidents and fatalities, alcoholic pancreatitis, and other causes of alcoholic disease. So we're looking at about 100,000 alcoholics dying every year. 3 times as many alcoholics die every year than die from all causes of opioid toxicity. Traffic deaths, about the same number of traffic deaths a year, many of them preventable. Caused by, compared to the 35 or 32,000 people who are going to die of opioids. And here's something which is near and dear to our hearts. Nearly 100,000 hospital-acquired infections every year kill people. We heard Stefan talk about hand washing yesterday, and many of these, if not most of these, could be prevented with compulsive hand washing in the hospital. So the lesson here is I just want to ask you, which are you going to be upset about? We have 650,000 deaths that are preventable. This doesn't include the deaths from hand washing or not hand washing. We have 600,000 deaths every year in this country that are preventable from substances that you can walk in and buy without a prescription at most Walgreens. And we have 33,000 deaths from, largely speaking, from non-medical use of opioids. So what upsets me is that we don't have the breastfeeding going on in the halls of Congress. We don't hear Otwald one day go on CNN and talk about any of these things, and yet they're 20 times larger in terms of a public health problem than opioids. And I don't know why opioids get so much press and these other diseases don't, except to say that there's a general opiophobia in this country. I think it has to do with a lot of puritanical thinking. And as you'll see in a second, I think that there's a strong element of racism that drives this. So we have 33,000 deaths from opioids overall, 14,000 deaths from prescription opioids, 12,500 estimated to be from non-medical use of those opioids, and we're left with 3,000 deaths, or about 10 deaths a day or 9 deaths a day from medical use of opioids, accidental overdoses, and even that's probably exaggerated, because if you go into the emergency room with cancer and you're dead and you have opioids in your bloodstream, it's going to be written off as an opioid death, where it might be something else entirely, a pulmonary embolism, for example. But in any case, that's 9 or 10 people a day in this country, which is not even a blip statistically, looking at the national mortality statistics. So let's look at some of the myths and the facts about this. Now, there is a strong ethnic or racial predilection to becoming an opioid addict. I think most people will agree with that statement. We come across this attitude as clinicians all the time in the hospital. But what surprises people, and one of my colleagues yesterday was surprised when I was talking about this, and this is somebody who's not in the room today but who deals with sickle cell pain on a routine basis, is that whites are far more likely to die from opioids than are blacks. How much more likely? This much more likely. It's a big difference. Whites have approximately 5 times the death rate from opioids in this country as blacks do today. Does that surprise you? I think it should. And this is the reason, in my view, why we have all of this inflammatory reporting and inflammatory language in the lawmakers' offices about opioids. Because up until the last 10 or 15 years, opioids were largely confined to the inner city, urban ghetto areas. If you lived in downtown Manhattan, you had to go uptown to Harlem if you wanted to score a packet of heroin. But today, these are the people dying of opioids. This is an article that was in the New York Times a month or 2 ago. It was an article that dealt with how is this man going to have his farm taken care of when he retires. He had 3 sons, 2 of them died from heroin overdoses. So what we're seeing today, largely speaking, are white boys dying from heroin, not black boys dying from heroin. And that has really captured the attention of a lot of people. Now, a lot of the blame for this has gone to the manufacturers of OxyContin, Purdue Pharmaceuticals, and other opioid pharmaceutical companies. And we now have, at last count, 3 or 4 or 5 state, what are they called? The head lawyer in the State Department of Justice, attorneys general. We have 4 or 5, I need my coffee, 4 or 5 attorneys general in the country who are suing in the same spirit as the tobacco lawsuits were filed by states, suing the pharmaceutical companies, largely speaking Purdue, for manufacturing narcotic medication and fueling the opioid epidemic. So let's look at that and where that came from. Now, I do believe that back in 1999, 2000, 2001, there was a lot of inappropriate marketing of opioids, particularly OxyContin. So OxyContin sales were very, very high in states like Maine, New Hampshire, Kentucky, and there's no doubt that those vice presidents of marketing and sales in the halls of Purdue Pharma, there's no doubt in my mind that they knew they were selling way more OxyContin pills in Kentucky than they had any right to sell based on the amount of pain that was in Kentucky. There's no question about that. They knew, and they were happy to take that to the bank. And then, of course, they paid a $2 billion fine to the Department of Justice of the United States, and when they pled guilty, and their president and CEO were lucky they didn't have to do any time. But that may have taken the lid off a problem, or it may not have. And we'll see right now whether or not there's any logic behind blaming the pharmaceutical industry today for this rapid rise in opioid deaths that we're seeing. The other thing that's blamed often is JCO. Back around 2000, it was recognized that pain was grossly undertreated in the United States. This was a rather notorious case in California where a cancer patient was allowed to die in pain. His family sued the physician for medical malpractice and won a $1.5 million award. And then, as if that wasn't enough, and I was actually happy about when I read this, I was happy the guy lost the money and that attention was being paid. I think most of you would have been happy as well. And then the state charged him with elder abuse and convicted him, and he served time. This family physician who undertreated a patient of his with analgesics, allowed this man with pancreatic cancer to die in pain, actually went to prison. And that was about when JCAHO decided to make pain one of their major foci of hospital accreditation. That's when the fifth vital sign was born. And in the state of California, the family didn't stop at suing him for malpractice, agitating to have the state attorney general charge him with a felony. They actually went to the state assembly and lobbied and successfully had a bill passed that required all California physicians to take a certain number of CME hours of training in pain management in order to get a license or renew a license. And that created a small cottage industry in California for people like me who are perfectly happy to provide CME courses for $500 a pop and tell them about pain management, which was, largely speaking, the treatment of patients with opioids. And so we saw a lot of opioid prescriptions going up. But what's happening today? Unlike the sale of Viagra, what's been happening with opioid prescriptions? So if we look just at OxyContin, you can see that OxyContin sales have been dropping year upon year since about 2010. In the meanwhile, we see opioid deaths rising rapidly. So it defies logic to me to say that this rapid increase in opioid deaths in the country, which is largely heroin and fentanyl, as I told you, it can be tracked back. We can connect these dots. It's not logical that we connect these dots to opioid sales. And this is true also for Vicodin and all other prescription opioids. The sales have been dropping since 2010, as has the non-medical use of prescription opioids. That has been dropping since 2010 as well. And this has once in a while captured the attention of the press, but not so much. So the point being that we have seen for the last 7 years opioid prescriptions falling, non-medical use in terms of overdoses and deaths falling, and I can't understand how people would conclude that the opioid crisis with the rapid increase of street opioid use is related to prescription opioids. We do have a small responsibility in this, and I'll talk about that. Now, our president has said many things since he's taken over the presidency in January, and this is one of them, that opioids are taking over our children. And one of the common themes that I've read is that the opioid use in the teen years that's prescription-based is driving the opioid epidemic by taking teenagers and turning them into addicts. So let's look at if there's any truth in that. Now, the symptoms and signs of opioid use disorder in adolescents are these. They're older teens, predominantly male. That doesn't surprise you. Overwhelmingly white. They are poor academicians prior to opioid use disorder. They are non-urban. This is not so much an urban problem. They often use substances other than opioids, and importantly, there's an overwhelming preponderance of psychiatric disease in this population as well as the adult population. Let's look at, see what opioid use has been going, what opioid use in our youth has been doing over the last couple of decades. Now, if you're not familiar with this series of papers called Monitoring the Future, you might want to download these. It's a comprehensive survey of recreational substance use amongst junior high school students and high school students that's been going on now for 4 decades. And this is what their data look like. Each curve represents a different grade level from 6th through the senior year of high school. And this is one of their graphs that's showing opioid use other than heroin in this population. These are all anonymous self-reports, and they're national in scale. They're sampling the entire country from coast to coast. So what I see when I look at this curve is this. If I track present-day opioid use back, while it's had some undulations and ups and downs, today it's no different than it was in 1970. It's opioid use, non-heroin opioid use, which is to say non-medical use of prescription opioids, is no more common in our children today than it was 40 years ago. And that's an important thing. So if the non-medical use, recreational use of opioids on the playground is driving the national crisis, we should have seen this national crisis in 1975, but we didn't. Opioid use and addiction was pretty infrequent in 1975. If we look at heroin and medical substances, you can see that they've all been decreasing since about 2010. And heroin has always been a very unpopular drug amongst teenagers, and remains so to this day. What about prescribing opioids in adolescents? There was a paper published a couple of years ago, which I would recommend, and I think these slides will be available so you don't have to scribble down the references. These authors tracked adolescents in the hospital who were given opioids for trauma and surgery, and they followed them longitudinally out for 7 or 8 or 9 years up until the age of 23, and they found no increase in the incidence of opioid use disorder in that population compared to other 20 to 23-year-olds. So we can't tell you on the basis of this paper what happens after the age of 23, but certainly there was no increase in opioid addiction in the population of adolescents given medical opioids for legitimate medical reasons. If you look at another paper published by a national survey organization, you can see that the majority of first offenders, first users of non-medical drugs or heroin are the older population over the age of 26. And largely speaking, surprisingly, over the ages of 40 and 45. And it's a small minority of patients who start opioid addiction in their teen years, and even a minority who start them in their early adult years. Now, why do I think this is happening, and what can I explain this by? Here's what I really think is going on. This is a map of the United States, obviously, and it's showing you the prevalence of opioid deaths in emergency rooms state by state. So the darker the state, the worse the death rate is. 2013, 2014, 2015, and this pattern increases. So you see more and more orange coloration and dark red coloration as we move into this time of rapid opioid deaths in this country. Now compare this map with this other map. The map on your left is the map of unemployment in the United States. And it's not an exact overlay, but it bears a remarkable resemblance to the map of opioid addiction and death. Very recently, just in the spring of this year, the National Bureau of Economic Research, which is based here in Cambridge, and it's supposed to be the most prestigious and unbiased, non-political economic organization in the country with 2 or 3 Nobel laureates on their staff, surveyed county by county every county in the United States. And their conclusion was that for every increase of 1 percentage point in the unemployment rate, there was nearly a 4% increase in opioid deaths and a 7% increase in opioid overdoses. Now, of course, this is correlation and not causation, but I think it's a very powerful observation that as unemployment increases county by county, so do opioid deaths. Just a couple months later, in April of 2017, the Brookings Institute, which is known as a conservative think tank in Washington, D.C., published this paper, which got a fair amount of press. I don't know if you saw it. They reported what they called deaths of despair in the United States, and they tracked it back from 2000 to present day. Deaths of despair were deaths from opioid overdoses, suicide, and alcoholism. And you can see from this curve that deaths of despair increased through all of these years, but exclusively in the white, uneducated population. These are white Americans, male and female, more common in males, but very common in females, with a high school education or less. Now, since the economic downturn started in 2008, who are the people who have lost their jobs? Who are the coal miners, the industrial workers, whose factories have moved to Mexico or China, as we hear from President Trump? These are the people who have lost their jobs. These are the people who are in economic despair, and these are the people who are turning, largely speaking, to opioids to mitigate that. These are the deaths of despair of men and women. So what we're seeing is that, once again, this opioid crisis is, largely speaking, a disease of middle-aged white people, male and female. It's not a disease of children. It doesn't start in childhood, as far as we can tell, and it's closely related to economics. As is alcoholism. This doesn't surprise you. You're 50 years old, you're uneducated, you lose your job, and you start to drink. And the prevalence of alcoholism has risen in parallel to the presence of opioid addiction and death in this country. And this has been called a national crisis, or a public health crisis, as well, by the authors of this paper, which came out last month in JAMA. The problem with giving a talk like this is that you have to really stay on top of the literature, because this is a 1-month-old paper. And I knew that I was giving this talk months ago. So there is so much information flooding the journals and flooding the lay press every day. There's about 12 articles in the press about opioid addiction. So what causes opioid addiction? It's a complicated problem, and of course, especially in politics, we like to think of simple solutions for complicated problems, and then we're surprised 5 years later when those simple solutions don't really work. So in the minds of most people, this is all opioid addiction is. You get exposed to opioids and you get addicted. But it's much more than that. About 60 to 70% of the predilection to become opioid addicted is thought by geneticists and opioid and addictionologists to be genetically determined. 60 to 70%. So clearly you have to have exposure to opioids to become addicted to opioids. If you live on a desert island and you never see a molecule of opioids, it doesn't matter what your genome says, you won't become addicted. But if you don't carry the gene for opioid addiction and you're exposed to opioids, you also probably will not become opioid addicted. How many people in this room have had opioids for one reason or another? I have. They made me feel like shit. It took the pain away, but I really felt crappy afterwards. And after I got my IV injection of morphine for a bicycle accident, I thought, oh good, I don't have to worry about that. It's one less thing in my life I need to worry about. But the three determinants, largely speaking, are exposure, which is 100% of opioid addicts, genetics, which is about 60 to 70% of the predilection, and psychiatric disease is very important. This is, largely speaking, also a disease of people who are depressed, bipolar, have personality disorders, narcissism. That explains Rush Limbaugh's issue with opioids. But you really need at least two or three or all three of these elements to become a person with opioid use disorder. Now, just a few words on what to do in terms of prevention. This is, I think, obvious to all of us in this room. So the simple solutions that have been proposed by legislators and pundits on the television ignore this. Above all, do no harm. So that didn't come out right. We have a tremendous risk of harming patients with draconian or simple solutions that are not necessarily logical and that ignore the evidence. So just to review, on every day of the United States, we prescribe about 500,000 or 2/3 of a million opioid prescriptions. And you can read this all the way down, and we wind up with 10 people or so dying every day from opioid toxicity. It's a very small number. It's 0.001% of opioid prescriptions lead to medical opioid deaths, and about 0.005% lead to of opioid prescriptions are affiliated with non-medical use of death. So it's a small problem, but it is a problem. I have 2 friends whose children have died of in their young adult years of opioid addiction. It's a problem that I'm conscious of when I give opioids to my patients. But if you are rational about it, you realize that the problem is not a major problem in terms of prescribing. And this is a great paper that was published on June 2nd of this year. And I suggest you read this. It's an editorial, and it's a very poignant story about written by a hospitalist about one of her patients with cancer who was harmed by refusal of clinicians to prescribe opioids when he was admitted with cancer pain in a terminal state. Now, these are the people that we're worried about. There's 100 million Americans who have chronic pain, as was pointed out in 2008 or 2011 by the Institute of Medicine with this book, which you can download for free, called Relieving Pain in America. I'm sure you're aware of this. 44 million Americans with severe debilitating chronic pain, and 12 million children in this country with chronic pain. These are the people who may be harmed by draconian solutions. And this paper, which came out just this month, is a very balanced paper. One of the co-authors, David Clark, is my colleague at Stanford, and that in JAMA that described the opioid epidemic, but cautioned individuals reading the paper that it's going to take a multi-pronged attack to solve this problem. It's a complicated problem. It's going to take years of effort, and there's not going to be a quick fix. Will strict limits on opioid prescription prevent addiction? This paper from Substance Abuse says that there's no evidence. They've reviewed the literature and the statistics, and there is no evidence. But on the other hand, we do know that strict limits on opioid prescribing is inhumane and has led to a number of, at this point, not statistical, but certainly anecdotal cases of suicides by chronic pain patients who could not get the opioids that they had been receiving for years to manage their severe debilitating pain. So at last count, there's 7 states that have passed strict limits to opioid prescribing. The most draconian is Ohio, which has passed a bill limiting opioid prescriptions to 3 days. 3 days, except in cancer patients or patients with terminal diseases. As if patients with non-terminal diseases don't have severe debilitating chronic pain. We see those patients all the time. Now, I'm not suggesting for 1 second that all chronic pain should be treated with opioids. I think most chronic pain should not be treated with opioids. We know factually that many conditions, severe chronic daily migraine headaches, severe low back pain, do not respond well to opioids and do respond well to multimodal therapy. So we should always, as the CDC has cautioned us, use non-opioids as a first choice and use multimodal therapy as a first choice, including physical therapy, psychotherapy, other non-pharmacologic means to treat chronic pain. But there are those patients with debilitating chronic pain from various conditions, including channelopathies like erythromelalgia, that have pain that cannot be adequately treated by other means. So this is not a solution that's going to work. We do need to look as a profession at inappropriate prescribing of opioids by our own colleagues in hospitals. So in this paper, they looked at whether opioids were used as first or second line treatment in emergency rooms around the country for migraine headaches. And I think most of us would agree that opioids are not the appropriate first line drug for the treatment of severe migraine headache. And that practice is pretty consistently true in academic medical centers, where it's used only about 3 or 4 or 5% of the time. But look what happens when you move into the urban hospitals, non-academic hospitals, and into community hospitals. You see, most of the time, the first syringe that is reached for a migraine patient is probably an opioid, and that's inappropriate. So, and opioids should not be prescribed to go home with migraine patients, and yet that's happening frequently also. So we do have our own act to clean up to a certain extent, but I'll remind you that even the prescription of inappropriate opioids to patients, some patients with chronic or acute on chronic pain, is still not what's driving this crisis in the United States. In the United States, there's 5.5 million opioid prescriptions per year in children, and they're predominantly prescribed by not people like you and me. Most opioid prescriptions to children are prescribed by dentists, not surprisingly. They're given a bottle of Vicodin to go home with after their wisdom teeth are extracted, and by emergency room doctors. So they come in with a sprained ankle and they leave with a bottle of Vicodin. And I would argue that that's also inappropriate medical use of opioids. Oral facial pain does not respond particularly well to opioids. Non-steroidal anti-inflammatories are far more effective for third molar extraction pain than are opioids. And I would say the same is true for broken bones and sprained ankles. The opioid should be a last resort, and when we prescribe them, we should be prescribing limited quantities. And yet we know that more than 50% of opioids are left over after the person is finished with them. What we don't know really very much as a profession is how much opioids our patients typically use when they go home from the emergency room or from the hospital after surgery. Do they need opioids for 1 day, 2 days, 5 days, 7 days? We don't really know, and so what we typically do is prescribe them for 7 days or maybe even 2 weeks so they don't run out. And that leads to an enormous amount of leftover prescriptions. Myron Yaster, formerly at Johns Hopkins and now at Denver Children's, has published a couple of papers on this. And a minority of patients are told what to do with their leftover opioids when they go home with the opioids. And I don't know how many of you tell patients what to do with leftover opioids, but most of us really don't do that. And 90% of those patients who are told what to do with leftover opioids don't do it. So I'm just curious, how many people in this room have leftover opioids at home? I do. Why? I have some Vicodin left over from a surgery I had 5 years ago. I actually didn't take any. I didn't need any. I just used Tylenol and non-steroidals, and I was fine. But I saved it, because I might break my ankle tomorrow just in case. And where do you keep them? Most people in the kitchen or in the bathroom. That's where we keep them. Even physicians with leftover opioids don't do what we are supposed to do. Yeah, great for open houses, great for when your teenagers have parties. Exactly. And so we're part of the problem as well, though again, it's a very, 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 very small part of the problem. So in a nutshell, I think this is my last slide, or my penultimate slide. There are things that I think we can do as clinicians and that our hospitals can do to help solve this very small part of the problem. But again, there's 33,000 people that are going to die in 2017 from opioid overdoses. And the number that are dying because we gave a teenager Vicodin for their third molar extraction is infinitesimally small. But we should be setting a high bar for ourselves. So what hospitals can do is support pain management programs and establish protocols for prescribing opioids. So those emergency room physicians are not allowing people, teenagers or adults, to leave the hospital with sprained ankles and broken ankles and other broken bones with 2 or 3 weeks worth of Vicodin. I think that's important. I think it's important for us to encourage our own hospitals to have opioid take-back programs. I think every clinic, every hospital clinic, every doctor's office should have a safe container for opioid disposal, so patients can be encouraged to bring those extra opioids in. The system that we have now in California, I don't know about your state, is that we have to take leftover opioids to a law enforcement office. And I actually tried to do that with my Vicodin. I went to the Menlo Park Police Station where I live, And I said, would you take this stuff? And they said, no, we don't do that. You have to take it to the county sheriff's office, which was 20 miles away in traffic. And I said, no way. I'm not driving 20 miles on 101 on a Thursday afternoon to throw away my Vicodin. And so I just stashed it in the bathroom where it stays to this day. People won't do that. It's not a reasonable expectation. But if they can drop them off conveniently when they visit the doctor's office the next time, that's something that they might do. So I think it's important for us to have it, and pharmacies as well, private pharmacies. But that creates a paperwork problem, and that creates an administrative issue for them, but they should be encouraged to work through those problems. So take-back programs, I think, are important. Checking out, right now in California and in many states, we are required to check a state database before prescribing opioids, so we can determine if the patient has been shopping around for opioids, using multiple pharmacies, multiple physicians. So we can check the database in California and determine every controlled substance that patient has been given for the last 2 or 3 years. And that's not a bad idea, but it's kludgy to do that. It's difficult. It takes time in a busy clinic to log on to the database securely. But I log on to Epic securely every day in the clinic, and there's no reason why Epic can't communicate with that database and show me the opioids that are in that database for that patient every time I open that patient's chart. So hospitals, and this can be done and is done in a couple of locations. So hospitals, I think, should be encouraged or even required by regulation to interface with state databases. Every state has one. And in fact, I think the database should be a national database, because if you live in Vancouver, Washington, it's only a few blocks to Portland, Oregon. And if you're a clever addict, you will just simply cross the border into Oregon, because you'll know that your Washington physician is checking the Washington database and not the Oregon database. So those are just some simple things that we can do that will make a small impact on a big problem. But I think we can talk more in the Q&A perhaps about what universities can do, what pharma can do, what government can do to solve this problem. And with that, I'll stop. Thank you very much for your attention. I don't think there's any evidence that they really are effective as a risk tool. But there are certain things that we screen for routinely. I do ask my patients about opioid use, alcohol use, tobacco use. So alcohol and tobacco use are risk factors in teenagers. History of sexual abuse is a risk factor. Psychiatric disease, particularly depression and bipolar disease, are significant risk factors. And I ask about a family history. That's in the first time I see a patient, we ask about a family history of substance abuse. So that's a risk factor, because as I told you, there's 70% or so of the predisposition to develop use disorder is because of genetics. So those are risk factors. But if I have a patient in chronic pain, what am I going to do differently if I think opioids are indicated and there's no other alternative for managing their chronic pain? That's the larger question. Gary?
So I hear what you're saying, and I think we've upped the ante one at Seattle Children's, because when we looked at our clinic population, there are actually very, very few people who are getting opioids for chronic pain. And what we do when that comes up is the person goes and is screened by a psychiatrist who's trained specifically in addiction. And I think us doing the screening is sort of superficial, and as you point out, you're basically hitting risk factors. But partnering with them, so they'll either say, I have no concern, or we need to work with you as you prescribe these opioids, has been incredibly helpful. And again, it comes up maybe 8 to 10 times a year. So it's not like it's this very frequent kind of issue that we're constantly bombarding them in psychiatry.
That's a good idea. How quickly can you get a psychiatric consultation like that?
So in general, it's a pain in the neck, and what I do is I basically call in a favor every time, and the guy sees them within a few weeks.
A few weeks. So in that few week interval, if your patient's pain is severe and debilitating, do you withhold opioids until you get the consultation? or do you go ahead without the consultation and do the refill pending the consultation?
So interestingly, the majority of the time, we're talking about patients who are already on opioids when they come to our clinic. And so it's a matter of keeping them on a relatively short span. Like, you're not going to give them 3 weeks of opioids until they can get in and see the psychiatrist. It's going to be something more like they need to come back every week, 10 days, something like that, to keep it going. Where it becomes really hard is when geography is an issue.
Yeah.
When you have these people that are coming from far away and that kind of stuff, it's much more of a challenge. And there's the ideal and then there's the reality, and I can't tell you what a formula is in those situations.
No other discussion? Wow, I thought there'd be more. Dan?
Right. So, about how many patients or what percentage in your clinic are getting opioids long-term for non-life-limiting illnesses? And talk a little, besides the erythromelalgia ones, talk a little bit about others, and are they for months, are they for years, are they for decades?
I can't give you a specific statistical answer to that question, and I can only talk about my own patient panel. But I'm thinking I can count on 1 or maybe 1.5 hands the number of my patients, like Gary said, who are on daily opioids for years or for months. So it is decidedly uncommon. And leaving aside those pain physicians in the country who are pill milled or pill jockeys and are basically pushers with an office, I think that's true for the vast majority of pediatric pain specialists and probably the majority, not the vast majority, but many adult pain practitioners. I guess we'll hear from Dan, who's one. But I think that the chronic use of opioids is the exception and not the rule. And a large problem in the country with inappropriate opioid prescribing can really be tracked back to primary care physicians and orthopedists in emergency rooms, which were, not coincidentally, the primary marketing targets of Purdue Pharma. They never visited me, but I know they visited orthopedic surgeons.
And how much do you use urine screening? And if you do, what do you do with it?
I have used urine screening, but not on a routine or random basis. So I've used it only when I've had a strong suspicion that something's going on. And the only positive urine screen, so to speak, was a negative urine screen, in which I was prescribing oxycodone, but it was undetectable in the urine.
We had someone recently who got a colleague came to me with 2 negative urine screens for somebody with I think an appropriate prescribing condition. If you don't order the screen the right way, you don't see it, and their routine screen for the prescribed methadone was negative twice because you've got to order it, and it depends on where you get it.
Yeah.
So I think that urine screens, if not targeted and if not saying what you're looking for, can lead to false accusations.
It's true. I think Dan had a question.
Well, I had a couple of comments.
Okay.
The first of which is to express heartfelt. I had just a couple of comments. The first of which is to express heartfelt appreciation for what is a great rarity nowadays, I believe, which is a dispassionate, logical view of a multifactorial situation that cannot be reduced to a slogan. So I'm going to applaud you.
Thank you.
A couple of other quick things. For those of you who are interested, there were a couple of people in the room who participated at the last World Congress on Pain. We did a satellite symposium from the Acute Pain SIG on the topic of Are Perioperative Opioids Obsolete? This is now available in Pain Reports. It's free to download. It's gone live. And it does touch upon many of the factors. Another comment is that in your slide depicting the actions of the drug plus genetics, other factors as determinants. I'm not sure, but you have actually duplicated what is a very typical figure in textbooks of public health, where the public health concept of disease, including and up to the WHO model of social determinants of disease, views diseases as an equilibrium between pathogenic factor, host, and environment. So your slide could well have been taken from a public health textbook, the relevance of which is that another feature of public health problems is that there is a social justice dimension. And I think that one of the things we need to hear more about is the role of stigmatization of patients with chronic pain in general, and certainly those taking opioids, by politicians and by society at large. Stigma is a huge part of the dynamics of chronic pain, and has driven, I think, a lot of the discoordinated torrent of activities to do that. So I'll stop there. I mean, this is something one can talk about for weeks, but I really wanted to commend you for just trying to respect the complexity of the problem and the fact that it can't be solved by this or that slogan. In fact, not to be flippant about this, but if a sense of loss of control and despair might be one of the factors to worsen addiction, you could put up a picture of the Christie panel and say that anyone looking at that would probably have an exacerbation of their sense of loss of control and despair.
Yes, thanks, Dan. And there's actually, along the lines of the public health comment, you made an interesting paper that I didn't include here that was written by a military physician saying that if we treated the cholera epidemics in London the same way they were looking at the opioid epidemic, it never would have been solved. But because you have to trace the disease back to its origins. And yeah. Any other comments?
I just have a question for talking points. So as we go back and we are promoting appropriate pain care in our institutions through ChildKind certification, as individuals or clinicians express concern that we might be encouraging inappropriate prescribing practices. What talking points would you recommend that we provide those individuals about the ChildKind process, and perhaps even metrics that we might look at to be able to support that that they're not competing interests?
Well, I showed you some of the metrics that are reassuring to me that that opioid exposure does not routinely lead to opioid addiction. Now, that isn't to say that there aren't teenagers who are exposed either by purchasing Vicodin or oxycodone on the street and then becoming addicted, or even being exposed to it medically and then continuing its use inappropriately. That certainly is the case, and they have those other risk factors almost all the time. And I think the challenge is to recognize those individuals prospectively and to manage them, that even known opioid addicts deserve opioids when they have severe pain that is opioid responsive. That's an important concept. And so prediction and then monitoring is very important. And I think Gary's method of monitoring is the most important, far better than urine tox screening or anything of that sort. So pill counting when they come back is important to make sure that they can account for all their medications, etc. But I think the only thing is to emphasize that there isn't any good evidence, except correlation evidence, which is not good, to suggest that children exposed to opioids will ultimately may become opioid abusers, and that's a risk factor. We hear all the time in the press that 80% of addicts have been exposed, or I don't know what the percentage is, but a lot of addicts who were exposed to medical opioids at one point in their life. It's not 80%, it's something like 20%. As if that's a significant factor. I can bet you that 94% were probably exposed to breast milk. But that doesn't necessarily mean that that is a cause of the opioid addiction that they get 30 years later.
And can I just add one other thing? If there is the thought, if it's being raised as an issue, that to sort of restrict practice in some way as a result of that, typically, if we can suggest, as has been suggested, that there is this sort of disconnect, number one. But number two, the other issue that's most important is that those same people who might be wanting to restrict opioids are not necessarily funding multimodal treatment of this. They're not providing psychological support. They're not providing the sort of more extensive support that we know has more documented efficacy, especially for crime. So I think that you can't have one without the other.
But Neil, I think we're overlooking something obvious here, and that is you're asking about the impact of ChildKind. And there are some cornerstones in the ChildKind model that directly hit on this issue. So for example, the fourth category is evidence-based approaches to pain. So if you're really using evidence-based approaches to pain, the likelihood that you're going to use opioids for a lot of the issues that are out there goes way down. A second cornerstone of ChildKind is education. And what you heard Elliot say is that when the detail people from Purdue came around, they don't go to the pediatric pain specialist, they go to the pediatric orthopedist, etc. So if you've got a major education program in your organization that would teach the appropriate assessment and treatment of pediatric pain, those are very, very powerful ways to address the issue. So rather than people being concerned that ChildKind would increase the risk of this stuff happening, I think you can make a really strong argument that it would be the exact opposite.
And the third cornerstone is the quality improvement. So again, that's the monitoring in terms of what's happening. So those three principles are really addressed.
I would just like to make a comment, because we live in a state in Colorado where marijuana is approved for recreational use as well as medical. We've had some parents who, the children do come up positive for marijuana. They have candy. They have all kinds of things that are very accessible. They're elderly who, by mistake, ate chocolate that they didn't know it was laced with marijuana. We've had some unintended consequences that now our practitioners, advanced practice as well as physicians, don't want to prescribe opioids, so they'll ask us. And the second part is we have now a policy, thank you, that we have at a high level how we allow parents to use CBD oil in the institution and those kinds of things. So a lot of dilemmas related to cannabis.
I actually didn't include these slides, but since the cannabis topic came up, I did want to include this. We have medical cannabis in California, and in, I think, 2 or 3 months, recreational cannabis will be legal. And the question comes up about cannabis as a gateway drug, et cetera, et cetera. So when you start to look at evidence, sometimes you find that your intuitions are wrong. And the state of Indiana, for example, they had they had an AIDS epidemic a few years ago when Mike Pence was governor. It seemed logical to people with a certain mindset that giving needles away to addicts was not a good idea because you're just going to encourage them to shoot themselves more. But it turned out, obviously, that's not true. And when Mike Pence was convinced to have a needle exchange program in the state of Indiana, the AIDS rate plummeted. So our intuitions are not always correct. And so I did want to point this out, that in this paper, which came out in 2014, they looked at the effect of cannabis legalization on opioid mortality. And this is what they found. And the interesting thing about this paper is they looked at what happened to opioid mortality in the state after cannabis became legal. And as you can see, it fell dramatically. So I think that it might lead to some rethinking about the appropriateness of availability of cannabis And that's, I think, particularly relevant to those who practice in the pain management world. I think there's a growing body of evidence that high CBD, low THC, cannabis extracts and tinctures are effective for pain. And if it is effective for pain, it's going to be much safer than prescribing opioids for the same pain. Nobody dies from cannabis. A lot of people die from opioids.
I would venture to say that there are people who are impaired who try and the indirect result.
Yeah, it's a small problem though. If you look at the National Highway traffic safety data, they've never recorded a traffic fatality in the last 10 years that they have tracked to cannabis.
Well, that's being pursued within our state, what is legally impaired with the substance.
Yeah.
how to determine that.
Yeah, I'm not advocating driving with impairment. I'm just saying that cannabis is safer than, what's his name, the golfer, Tiger Woods, just drove his SUV into a pole and was arrested, and the paper just this week released his toxicology screen. I don't know what happens to HIPAA and why the public is entitled to know, but I mean, he had a number of substances, mostly benzos and opiates in his blood. He didn't have cannabis. I think alcohol and opiates are far more deadly than cannabis. I'm not advocating that we all go out and smoke cannabis, but I'm just saying that as a substance to abuse, I'd rather have a patient abusing cannabis than abusing opioids. Dan had his hand up a second ago.
Okay, very quick comment, which is on the same kind of contrary way of thinking. As we sit in this room,
Sweating.
we could probably identify, we all know what is the most firmly established predictor of the development of chronic pain after acute pain, which is the intensity of, in other words, undertreated acute pain is to date the strongest identified risk factor for the development of chronic pain. So going back to the common public health scenario, where a very logical, simple, unimodal solution is proposed for complex things, if by stigmatization of opioid use and by marginalization of pain control, even in the hospital setting, such as the age caps controversy, we wind up on a population basis doing a worse job in controlling acute pain. That's the single most effective way that we know of to ensure that there will be a population with chronic pain created by our well-intentioned intervention.
And I'll just add a footnote to the question that Chuck asked me about the frequency of opioid prescribing in my own practice. And I'll say that while I can only think off the top of my head of 6 or 7 or 8 patients that I have who are getting chronic opioids, 3 of whom have erythromelalgia, I have about 20 patients that I've recommended CBD to, and I track them longitudinally. So it's 4 times as common for me to prescribe cannabis extracts to patients than opioids.
Just, Elliot, to follow on that, our state had medical marijuana a few years ago and developed pediatric as opposed to adult recommendations around it. In forming policy for Boston Children's, we looked around the country, and the document that Jeff Lincoln made for in Colorado seemed rational and seemed reasonable in terms of what you do with someone coming in a hospital who's already taking it. The dilemma that's occurred is that was with the previous president and the previous attorney general, and the official stance of the federal government was to be deferential to the states, remarkably, with a Democratic president. And many hospitals, so in Boston now, the official policy of the Dana-Farber Cancer Institute is we don't allow any cannabinoids, and Brigham and Women's. And our hospital, where kids with CBD oil for Dravet's and other forms of epilepsy would come in and use it, having gone far along on that, our because of the threat of loss of federal funding, our hospital's official policy is to have no, or the chief legal counsel, is to have no policy on cannabinoids and to put nothing on public materials about them because of fear of loss of federal funding.
That sounds like something a lawyer would think of.
You bet.
And because I'm a news junkie, and I can't think of a time when we've heard a threat coming from President Trump or the Attorney General Sessions threatening institutions and medical institutions, particularly with loss of funding. So they're just trying to preempt that?
Somewhere there was some statement about loss of federal funding, and it was in response to that that Dana-Farber and Brigham chose to, and our hospital, they made explicit policies against. Our hospital chose to make, as an official policy, we're going to say nothing and stay out of it. So they're neither officially against or officially for, they're officially silent, despite all of us shaking our heads.
Well, we don't have it on the formulary, but
No, we
not
don't have
yet.
the formulary.
But we allow parents to bring it in and administer it at the usual dose.
We used to, and now we officially, it might happen, but it's not officially talked about in any way.
So why don't we just
Okay.
finish that